care facilities. And summarizing the history, the 42-year-old gentleman whose direct occupation came to OPD with the complaints of gradually progressive painful swelling over the left scrotal region for the past 2 years. No previous history of trauma, no other comorbidity present. An examination of scrotum. After applying consent, the patient was examined in a well-lit room in standing posture, ensuring adequate privacy. The patient was exposed from umbilicus to midline in the presence of male attendant. An inspection, there is a swelling of left scrotal region of size 15 to 9 cm, vertically oval in shape, extending from root to the base of scrotum. A skin over the swelling stretched, normal viscosity is lost. No expensive or skin. It is irreducible on inspection. Prominent superficial veins are present, no redness over the swelling. Right scrotal and testis is normal and penis is normal. Palpation. No local range of temperature and not
inspection it is not reducible. Inspection your testis is normal. How do you say that?
Inspection, the swelling is not reducible.
Absolutely, what you say absolutely makes no sense. And that way the diagnosis, it doesn't make sense at all after this.
And you are said you are examined on standing position. That is what we understand. On a patient you are examined on a standing position. On an inspection you are saying it is not reducible and testis is normal.
Could you see the testis on right scrotum and testis?
Whatever it is, right or left, can you see the testis? Testis is present, you can say, the undescended testis. But you can't say that it is a normal testis. Don't make, because that is very important. That is only you are going to see palpatory finding. That is not an inspectory finding.
On palpation, there is no local range of temperature, not tender. All inspectory findings are confirmed. Consistently cystic fluctuation test is positive.
What do you mean by all inspectory findings are confirmed? You never said the shape. Vertically over. Okay. That is, you need a confirmation by the palpation. How do you confirm by palpation? It is vertically over. You see?
What Sir is trying to say is that there is no need to say all this. No?
You have said something, inspector is different. Anything which is important you can say. Here. Is there a consistency called cystic? Is there a consistency called cystic consistency?
There is also say confidently when you have confidence in yourself. Cystic is a consistency, is it not? So then you say this. Who is stopping you from saying this? But after that you go to fluctuation is positive. It is only after you would have done this test you would have said that consistency is cystic. Could you have said that the consistency is cystic without doing fluctuation? There is just no point of writing the two together. Once you say it is cystic, means fluctuation is positive. We'll ask you why did you say it is cystic?
Thyroid paradox over here. Okay. How did you do the fluctuation? That is massaging. That is called massaging. Always you
He knows man, which is not reflecting on anybody. It's a joke. Is there any other way to do fluctuation and how many directions are supposed to be made? Is this enough that you hold it in half? In two directions.
will it go or not? Is that what we are seeing in the fluctuation? You need to fix both the side and the solution be fixed. Not on one side you are going to do that. And both the direction you must do.
Able to get about the study. And the concept of parallel is not enough.
Why you are very particular? You have said 3 times able to get above the solid.
So because you differentiate the equivalent.
Is there any hydroxyl where you cannot get to?
Yes, sir. Even till the deep
Very good. Go ahead. No. Translumin is the picture. You are done. So where you are keeping the torch?
The torch should be placed laterally to the surgeon and the universal should be placed in front. So TV should be 90.
For this case, you need to go.
Hello.
Examination room dark. Fine. You said no rugosity. Mean by rugosity? It is produced by what? So more surface area, more heat will be evaporated, less heat will be conserved. Very good.
No parallel nose and other systems are being in order. The diagnosis probably a case of left-sided primary vaginal hypertension with no complications at present. And the investigation I will
Why do you say this primary hypertension?
and because they are already examination is clear fluid.
Clear fluid, you can't make it out. Transluminance.
Transmission was a
So
large.
you need to say in secondary or secondary hypertension transformation will be absent.
The question is, how will you differentiate primary from secondary? Or why not it is a secondary?
Because the test is not parallel and it's a large size study.
So points in history, that you did not find any cause for hypertension in history. Points in examination, that it's a dense large hypertension, which is more likely to be primary. In secondary hypertension, it is usually a lax hypertension and underlying pathology in the testis we are having. Right? Can you validate the epididymos also? What are the parts of testis that you validated? Can the testis and the epididymos be validated separately, or is testis validated as a single smooth open square?
Which is anterior, which is posterior? Where do you?
So, any pathologies that you can diagnose for validating the epididymos?
So why not it is epidermis? What is Chinese language? Completely palpable? Wait.
In the large case primary vaginal hypertension, you may not be able to validate all parts of testis clearly. But if it is an epididymal cyst,
That is posterior, no? The epidermal cyst and goes swelling posterior. Anteriorly the testis will be.
which is medial hypertension and medial epididymals. And
Due to? Madam asked bearded epidermis. Suppose in the history when the patient came to you, he said there is a pain, acute onset of the pain. What you would have thought?
I expect infection, acute epidermolysis, maybe of tubercular syphilis, biliary infections.
That will have a fever, rigor. Patient is not having that. He has an acute pain.
A torsion, I expect a torsion.
Torsion. What do you mean by torsion?
Rotation of the legs.
What is volvulus?
Rotation of
Both are same. Is there any difference between torsion and volvulus? Torsion is on the own axis, the vessel. That is on the mesentery or the broad base it is attached. It's not volvulus, is not rotation on that axis. Okay, go ahead. How do you differentiate? You said epidermolysis you will think or the torsion you will think. So how do you differentiate?
Sir, that's a sign called the one sign that we lifted it in epidermis, the pain is ready.
Why?
So because if the vein is the gravity pull,
Gravity pull.
there
There is no gravity. That is done in the moon, so there is no gravity. No, what is the problem in torsion? It is an artery. Epidermolysis is a venous congestion. When you are elevated, the venous congestion will be relieved. It will become down. In an artery, it is against the gravity, the blood has to flow. The pain will come. It's very, very rare. I mean, it's not very commonly present sign. Though we textbooks all describe that. Okay.
What is this inverted ache portal effect? Inverted ache portal effect.
case of congenital hypertrophy, the fluid will accumulate, whereas it doesn't go so ahead, but in superimposition it goes
What is the reason? Why
Reason.
does it happen?
inverted and inverted.
Why?
Have you ever done that test?
Like,
Have you ever done that test? You will say there is no ink bottle. At least with the Coca-Cola, I will inverted Coca-Cola sign. So take a Coca-Cola, open it and put it. Will the water come in a full or in a bit it come?
because of letting of the momentum,
So there is processes vaginalis that is there, which is a thin dot structure. So all the fluid which is accumulated in tunica vaginalis does not get emptied out immediately. By the signs it bulges by the side of the tunica processes vaginalis and causes more compression. Once you lift it out, it will not get emptied out. But when the patient is lying down, the fluid gradually drains into the peritoneal cavity. What are the other types of hydrosis that you know?
from etiology, congenital acquired brain from anatomically it is vaginal hydrocele, infantile hydrocele, congenital hydrocele, and cystic hydrocele of what?
Can you tell me one test to diagnose insistent hydrocele of the cord?
Fraction.
What is that?
Sir, if I pull the testis down, cystic hydrocele also comes up. And
So one is that you will be able to feel the testis and the swelling separately. Will be a gap in between, the cord will be parallel in between, and then when you will pull the testis down, the swelling goes down.
So what is congenital hydrocele? What is congenital hernia?
in congenital hydrocele, the oviduct is so small, whereas the hernia is a large effect. So the visual content cannot go down.
Very good. Very good. So what is the treatment
Hernia.
for both?
Investigations, I don't know.
What is PV ligation? Process vaginalis ligation. If you see now the late standard now books, pediatrics books, they don't use the word herniotomy. They use the word PV ligation, PV sac ligation, or process sac ligation.
The investigation I will use SCROTAL, and that investigation chest X-ray and protein immuno examination.
USG scrotum. What is USG? Ultrasound is a machine. You're taking the, what is ultrasound?
Using the ultrasound waves, we
That is what I am asking. What is that ultrasound means?
Sound wave.
So there is sound wave, there is ultrasound wave.
Ultrasound waves, we are measuring the
So what is the unit of sound? Hertz. You have increased frequency of more than up to what sound you can hear?
20,000.
Okay. So any sound which is not here, like ultraviolet light, any sound which you can't see, then some sound you are going to do.
And the treatment here is Jayalal procedure.
Why not Lord's procedure?
The last ligation is done for thin small set.
You said very brilliantly transformed and it is only a thin cell.
Thin set.
Okay.
So like it's not small set, already 15 cross 9.
Okay. So what is Lord's prescription?
The last ligation we are just opening the sac and trying to look out and we are just doing intermittent session.
So what is our objective? What is the purpose?
The principle is to increase the absorption of
Increase absorption.
we are creating channels so that we
No. No. What is your Jayalal procedure? Why do you do abortion? What is the principle?
because the absorption of fluid by the total impact.
There more. What are the mechanisms? One is secretion and decrease absorption. The secretion will be. Can you do laparoscopically? There is few papers has come now. Even trocar, Bailey love supports that. Putting aspiration. We don't normally advise because there you do aspiration.
So the exists of sac. Big sac or egg office.
No, normally lab and aspiration also we don't advise. So don't do that.
Can the hydroxy be non-transluminant also? Can the hydroxy be non-transluminant?
Yeah, with the sac.
Tell us the causes in which the swelling in this scrotum will be cystic but translumination will be absent. Hydroxy. Okay, tell us non-transluminant.
Big sac. Improper technique.
Okay, correct, yes.
That is genuine, we say.
What is the color of hydroxy fluid? What is the normal color of hydroxy fluid? Amber color. What is the color of hydroxy fluid when it is a non-standard hydroxy?
What is your favorite ice cream?
Wrong question. So it will be white. Any fluid which is there in the body for a long time will become white in color.
So you will become a good engineer. You are talking too much on that. What is hernia of the hydrosis? What is the hydrocele of the breast? T10. What is hydrocele of the canal of neck? Cystic hygroma. Lymphatic cyst in the breast can be a hydrocele of the canal of neck. Good, excellent.
Good job.